Okay, so this is the second part of the muscular system chapter. And then we already covered the muscles of facial expression, muscles of mastication, muscles that we use to move the neck, swallowing, and we're going to continue with more muscles, now the ones that move the head and the neck. So in the lateral part of our neck, we have a couple of muscles. Well, we have three muscles that are the scalenes, and they are subdivided into anterior, middle, and posterior. And these scalene muscles help us typically to do lateral flexion and rotation, but also help us to have deep inhalation when someone, for instance, is doing exercise, because they help to elevate the ribs. So they are connected between the transverse processes of the cervical vertebrae and the upper edge of the first and second rib. Now, the sternocleidomastoid that we saw before, it is a muscle that it is very powerful to maintain our head looking directly straight ahead, so it keeps us erect, looking in the front. And this muscle, which is inserted from the sternum and the clavicle up to the mastoid process, remember, when you flex it, the head to one side, the contralateral side is contracting. And then when you contract both, you can look straight ahead. So that's the sternocleidomastoid. And the sternocleidomastoid, it provides us with anatomical landmarks in the neck, so you can subdivide the neck into triangles, like the anterior triangle and the posterior triangle of the neck. And then for these two muscles, splenius, we have capitis, which is superior to the cervices, but they are located superficially in the neck, posterior neck area, just deep to the great muscle that runs between the neck and also the upper part of our back, which is the trapezius. These splenius help us to also maintain erect the head, because it extends the neck and also can rotate the head. Now, all of these muscles provide a framework in the neck and also help us to provide movement of the neck area and support respiration when it's needed. Especially will be the scalenes and the sternocleidomastoid, which is also another muscle, or it's called accessory muscles of inhalation, that help us to breathe when we need to breathe more. And actually, you can see it pretty well when someone has respiratory distress. When someone breathes, you can see better the popping of this sternocleidomastoid muscle. So here is the view of these muscles, where they are located and how they are inserted. So here is the sternocleidomastoid. It inserts one of its heads, this sternocleidomastoid, in the lateral edge of the manubrium, also in the medial edge of this clavicle, and goes and extends into the mastoid process. So actually, remember, we have as a rule that the origin of the muscles, it is proximal and the insertion is distal. But in this case, the origin, it is distal and the insertion is proximal. So this is one of the exceptions to the rule. And now here we have the three scalenes. So the posterior scalene connects into this angle of the second rib and then runs into this lower vertebrae, that transverse processes of the lower cervical vertebrae. It doesn't include the atlas, as you can see here. And then in here, we have the anterior scalene, and this is part of this middle scalings. This is the posterior view of our neck and upper back. So you can see the splenius capitis, which is superior to these splenius cervicis. And as a reference point, this muscle inserts into the spinous processes of the lower cervical vertebrae and upper thoracic vertebrae, and runs obliquely with its fibers running up, and also inserts into this mastoid process. So then when you contract this muscle together with this, you not only have a superficial flexion, but actually you can flex your head so much that it can lie down in your shoulder. And as well, you can turn back like this with these muscles. Okay, now let's move into muscles of the vertebral column. So these muscles of the vertebral column are grouped, and then we have muscles that erect the spinae, the spinal column, so they are called erector spinae muscles, and they have subgroups that are located in different areas of the spinal column. So for instance, we have spinalis, which is one of the muscles that is most medial, is closest to the spinous process, and is subdivided into capitis, cervicis, and thoracis. So then, if you remember the terminology from the beginning of the semester, capitis means what? Head. So this one then is located here toward the head area, the capitis, and then the cervicis will be located where? In the neck area, and then thoracic, then of course in that thoracic area. Okay, then we have the longissimus, which is on the side, is lateral to this muscle, the spinalis, that runs also in the similar areas where the spinalis is located. And then we have the iliocostalis, which is a little bit lower than the longissimus, and is lateral to the longissimus. So this one has three portions: cervicis, thoracis, and lumborum. As a whole, they extend the vertebral column, but in the case of this iliocostalis, helps to flex the vertebral column laterally. So when we do this movement, this lateral flexion, we are using the iliocostalis. Now, for the deep muscles that help us to maintain posture and produce spinal extension, we have the semispinalis, the capitis cervicis, and the thoracic segments, together with the multifidus that helps not only to extend the vertebral column, but also to rotate like this. Okay? And then we have the quadratus lumborum, which is the lower of these deep muscles that help us to flex the spinal column, and also helps to fix the 12th rib during breathing. And since it's located in this area, it protects the kidneys. So this is one of the muscles that protects the kidneys. So here is then the location of all of these muscles. So here we have the erector spinae with the spinalis capitis here. And then here we have the longissimus capitis, spinalis cervicis, and then this is the longissimus cervicis in this area. And then we have the iliocostalis cervicis here superior to this spinalis thoracis, longissimus thoracis, and the iliocostalis thoracis. And then here we have the iliocostalis lumborum. Now, the deep muscles will be the semispinalis capitis together with the semispinalis cervicis, semispinalis thoracis, multifidus, and the quadratus lumborum, which attaches into the 12th rib and also into the crest of the iliac bone. So it forms like a shield in this area. And this is important because, again, we have the kidneys located in this area, and the kidneys, they are not protected by bones, mostly, with the exception of the protection that they can receive partly with this 12 rib, which is very tiny, but and still in this upper portion, we have part of this muscle that helps to protect the lower lobe of the kidneys on both sides. Okay, now for muscles that help us to breathe, we have the diaphragm. The diaphragm is a muscle that looks like a dome and that separates the thoracic from the abdominal cavity. It is having a central tendon that it is pierced by three structures: the aorta, the esophagus, and the inferior vena cava. And then as it is inserting from the fibers that runs from the central tendon into the lower ribs, it will help to pull these ribs down during inhalation. Actually, this muscle, it is the one that is responsible to bringing 2/3 of the air into our lungs. And then this muscle, when it's contracting, goes down, compresses the abdominal contents, expands the thoracic cavity so that we can inhale deeply. And then in order for us to breathe out or exhale, we relax this muscle and then goes up and then helps to compress the lungs so that we can exhale. This muscle, it is innervated by the phrenic nerve. And the phrenic nerve is made by 3 roots of cervical nerves, which is C3, C4, and C5. So, there is a saying, C3, C4, C5 keeps the diaphragm alive. When someone has whiplash accident, it can damage these spinal roots, the cervical C3, C4, C5. If it does so bilaterally, both phrenic nerves, the right and the left, will be paralyzed. That will cause paralysis of the diaphragm, and the person won't be able to breathe in its own. So it needs to be put into a ventilator. So then, if you remember, this area of our spinal cord is very important, the cervical area. Remember what happens as well when someone breaks the allantoic process of the axis. It can go into the spinal cord and the person can become paralyzed, neck down. Okay. So then it's critical that we take care of this area. And then these openings for the IVC, the inferior vena cava, for the aorta, and the esophagus are called hiatuses. Sometimes some people can have a greater opening for the esophagus, and part of the stomach can go up from the abdominal cavity into the thoracic cavity. This is called hernial hiatus in the diaphragm, and then the person will have a lot of acid reflux into the esophagus. So they need to perform a surgery to close that little opening. Now for other muscles of respiration, so we have the external intercostals. So the external intercostals, they connect the upper edge and the lower edge of the ribs, of the costae, and they run downward and forward. So these external intercostals are used during inhalation. They cause us to breathe the other third of air into the lungs when we are breathing. The first 2/3 are brought by the diaphragm and the rest by these external intercostals. And then the internal intercostals, which runs opposite to the external intercostals, they depress the ribs and they cause exhalation. One way that I remember which one are inhalatory and which one are exhalatory is just remembering of the opposite of the first letter. So external, E, is for inhalation, and then internal is for exhalation, because you have starting with same letters for inhalation and exhalation. So then these ones depress the ribs during forced exhalation. So when does this forced exhalation happens? Because we actually do not need to spend energy to exhale. We have elastic tissue in our lungs that compresses the alveoli, plus the relaxation of the diaphragm that compresses the lungs help us to breathe out the air or exhale. But then exhalation, it's supposed to be a passive process. But then it can become an active process where you use ATP when you have, for instance, some obstruction of the airways, maybe a tumor that is compressing the bronchi, or maybe someone is asthmatic, and then the person is having problems of breathing. So then here are the diaphragm and the intercostals. So it has a dome shape, so this is the inferior view, so it's like a transverse cut in this area, and this is the central tendon. This is the opening for the esophagus. This is the opening for the inferior vena cava, and this is the opening for the aorta. So then it extends its fibers from this central tendon, connecting into the lower edge of the ribs. Now for these external intercostals, they run with the fibers obliquely and anteriorly from the lower edge of the ribs to the upper edge of the ribs. And then the internal intercostals, they run in opposite direction. They run obliquely, but in this case posteriorly, and then they can depress the ribs while these ones elevate the ribs. Every time that you elevate the ribs, you expand the thoracic cavity anteriorly and also laterally. And these ones do the opposite. It depresses the thoracic cavity. So these ones are exhalatory, these ones are inhalatory muscles. Now, muscles of the abdominal area. So we have superficial muscles, we have deep muscles, and then they help us majorly to compress the abdominal contents and also to flex our body like this, flexing the thorax over the pelvic area or vice versa, depending on your position. So if you're standing supine, then you can elevate your pelvis and then reaching the thoracic area. So we have the rectus abdominis that is located anteriorly and medially. We have two segments, right and left, that is subdivided into 4 little segments each. Through these tendons that are called tendinous intersections. That makes the muscles that we call the six packs. Okay? And then laterally to this, we have the external oblique, which fibers runs obliquely, downward, and anteriorly. Rectus abdominis help us to do this flexion, and the external oblique and the internal oblique help us to do rotation and a little bit of lateral flexion. So if someone wants to work out their abs, they have to do this when standing or doing this, and when they're lying down, they do the crunches. Now, if you want to work out your obliques, you have to do this type of movement and also this type of movement. So it is a composed movement in that case. So this is protected by a sheet that we call the rectus sheet. And then in the middle of this rectus sheet, connecting the right and the left, we have the linea alba. The linea alba is called linea alba because it means white line. So this one means line, and this one, albus, means white. So this is the connective tissue joining the heads of the rectus abdominis. So this is the line, the reference point that surgeons uses to perform surgeries, usually when they are exploratory of the abdominal cavity. So they can open from the xiphoid process up to the umbilical area, or sometimes they can even go down up to the pubic symphysis, and they open and then see what is wrong with the patient. So they use the linea alba to cut it. And then for the external oblique, it forms the inguinal ligament and its inferior border. So the inguinal ligament, it is part of this structure that is going to form the inguinal canal. The inguinal canal, it is formed by different lower tendons or fibers of collagen in the groin area through which some structures runs. Like in the case of males, it runs the spermatic cord, and then the testicles descend through this inguinal canal during development in utero. And then we have the round ligament running in there in females. Now the internal oblique is deep to the external oblique, and it does the same function, laterally rotates, but the fibers runs in a different direction. And the transversus abdominis, which fibers runs in a transverse manner, cross like this. This muscle, it has the property of contracting and help us to increase the intra-abdominal cavity pressure. We use that during urination, defecation, childbirth. So here is the view of all of these muscles. So this is the left rectus abdominis without removal, as in this case. We have 1, 2, 3, 4 segments caused by these tendinous intersections. This aponeurosis, which is the rectus sheet, it was removed, and both the left and the right side are joined by the linea alba. And now, if you remove this rectus abdominis, you can see here the internal oblique, and this is the external oblique. And then if you remove a little segment of this internal oblique, you can see the transverse abdominis. This is the lateral view of the external oblique. It connects to these ribs in here and to the iliac crest. And then the internal oblique, which is deep to the external oblique, it connects to lower ribs. So it can produce flexion, lateral flexion and rotation of the abdomen, but not as powerfully as this. And then finally here, deeper to all these three, we have the transversus abdominis, that the fibers runs in a horizontal manner towards the edge of the rectus abdominis. Now, if you remember from when we studied the abdominal cavities, the cavities of the body, thoracic, etc., we said that this one is the one that is having less protection, because digestive organs, although they are important for life, they're not as important as the lungs and the heart. But then, not because these organs, digestive system organs, are not as important, that means that we will leave them unprotected. One of the protection will be these muscles of the abdominal cavity. And what better way to protect them than to have the fibers of these muscles running in different angles and having more than one layer of muscles. So it's like a structural strength that we have to protect these organs. And now, muscles of the floor of the pelvis. So we have the pelvic diaphragm. So we have this group of muscles, the levator ani group. We have the pubococcygeus, iliococcygeus, and ischio-coccygeus. All of them insert in the coccyx, but they have different origin. So this one originates in the pubic bone, this one in the ilium, and this one in the ischium. All in the coxal bone, with these three different bones: the pubic, the iliac bone, and the ischium. And these muscles forms the floor of the pelvis, together with other ones like the transverse, the perineal muscles, etc. So the function is to prevent the organs of the pelvis from not having support, of course, and as well to help us to maintain continence. So if you make a transverse section of the pelvis area and you see it superiorly, you will be able to see these first three muscles that form the levator ani. So this is the pubococcygeus. Remember, here is the sacrum, and at the tip of the sacrum we have the coccyx. So then this one that runs between the pubic bone, which is this, and the coccyx will be pubococcygeus. And then this one that runs from this part of the iliac bone to the coccyx will be iliococcygeus. And then we have here on the sides the ischial spine from the ischium. So it runs here from the ischium into the coccyx bone, so this will be the ischio-coccygeus. And then we have other muscles like the piriformis here, and all of these are deep muscles. Superficially, we have other ones like the transverse perineal and others. And now here we have openings in this area. So this one is opening for the anus. This is for the vagina in females. And then here we have the opening for the urethra. So all of these muscles in here, like the transverse perineal, which is this, form part of what we call the urogenital diaphragm. So then in the urogenital diaphragm, we have the deep transverse perineal muscle, we have the external urethral sphincter, and then we have the superficial muscles of the perineum that are a little bit lower than the ones that we saw before, which are the ischial cavernosum, bulbospongiosum, and the superficial transverse. So in the case of the ischial cavernosum, in the case of males and females, it has this function in sexual intercourse. In the case of male, leads to erection of the penis. In the case of females, erection of the clitoris, which is the analog of the penis. And then for the bulbospongiosum as well, it is used in males for erection and also for ejaculation. In the case of females, it's for vaginal constriction during sexual intercourse. And for the transverse perineal, it helps to stabilize the other muscles that are around. So it's the one that we saw here. This is a transverse perineal. So now for the external urethral sphincter, this one is made of skeletal muscle, of course, and it is under voluntary control. It helps to control voluntary urination. And in the case of the deep transverse perineal, which is deep to the superficial transverse, it helps as well to support the pelvic organs. So it's part of the urogenital diaphragm. So here is the location of these muscles. So this will be the muscles in the female and here for the male. So this is the superficial transverse perineal. And then here we have the levator ani that we saw from the superior view in the previous slide. And this one is called the ischial cavernosum. And this will be the bulbospongiosum around the vaginal opening, which is this. And in here is not labeled, but we have the external urethral sphincter, which you can see it here. And then this is the deep transverse perineal, all of this in here. Now, in the case of males, here is the ischial cavernosum running from the raphe of the base of the penis sideways. And then here we have the ischial cavernosum, the superficial transverse perineal, and the levator ani. If you remove these muscles and see deeply, so this is the deep transverse perineal, this is the external urethral sphincter. Any questions so far? Okay, so all of those then were muscles of the axial skeleton or axial muscles. Now let's move into muscles of the appendicular skeleton. So first, muscles that move the scapula. So we have trapezius that helps to elevate, retract, and rotate the scapula. This muscle, it is well developed in swimmers when they do this, okay? Levator scapulae, it runs from the superior edge of the scapula into the coracoid process and also into the greater tubercle of the humerus. So this one elevates the scapula and tilts the glenoid cavity inferiorly. It helps to stabilize the head of the humerus in the glenoid cavity. Rhomboids, we have major and minor that both retract the scapula, like when you're doing this, to stabilize it. And then we have serratus anterior, which helps to protract the scapula, so it is an antagonist of the trapezius, and it helps to hold it against the thoracic wall. This is one of the muscles that are harder to work for people who do weightlifting. But when they are well developed, they look really, really good. And then we have this deep muscle from the pectoral area, which is the pectoralis minor, that helps to protract and depress the scapula, but also helps to elevate the ribs during forced inspiration. So then we have now several muscles, accessory muscles of inhalation that we have seen so far, and there are the following. So we have accessory muscles of inhalation. Okay? And then so we have pectoralis minor, sternocleidomastoid, and scales that help us to breathe deeper. And then we have the ones that help us to force the air out of our lungs, which are the abdominal muscles, the rectus abdominis, and then we have the internal intercostals. I might have said wrong in terms of when you use these muscles for forced exhalation. These are not used in asthma, actually. In asthma is when you need to breathe more. So in asthma, you use this. But these ones you use them in emphysema. In emphysema, persons don't have as much as elastic tissue, and they have to force the air out. Because regularly, we're supposed to compress our alveoli with this elastic tissue, but they don't have it, so they keep the air inside. Okay? But these ones are also used when someone, for instance, have a tumor that is compressing the airways. Not so much air is coming in, so they have to breathe with more force. And sometimes you can even see the retraction of the spaces between the ribs when they're doing that movement to gain more air. Any questions? Okay, so then here is the location of these muscles. So this is the trapezius. It has like a trapezoid shape. It runs from the spine of the scapula up to these spinous processes of the upper cervical vertebrae. It has here this tendon in between the between the lower and upper vertebrae. And then it has some fibers that runs obliquely internally and then downward that connects to all of these thoracic vertebrae, including the upper three lumbar. And then here we have the levator scapulae. From the superior edge of the scapula up to the transverse process of the first cervical vertebrae. So it helps us when it contracts to elevate the scapula. That's why it's called levator scapulae. And then we have rhomboid minor and rhomboid major. It runs obliquely up towards the transverse processes of the upper thoracic vertebrae. Why this one is minor and why this one is major? So look at the sizes. This one is very narrow and this one is broader. And then it makes sense that if it's connecting this medial angle of the scapula to these spinous processes, when you contract them, what would you do? You will retract your scapula. And then other muscles that you can see here, this is the supraspinatus, infraspinatus. And then here we have superficial muscles of the thorax. So this is the pectoralis major. If you remove it, you will be able to see these three heads of the pectoralis minor. That if you see, it connects to this edge of the ribs, upper edge, closer to the costal cartilage, and it connects to the coracoid process of the scapula. So when you have contraction, you elevate your first ribs, which is the second, third, fourth, and fifth, helping to aid in inhalation. And then here we have the serratus anterior. Now for muscles that move the arm and the forearm. So we have deltoid, pectoralis major, coracobrachialis. Those are anterior and lateral muscles. So this shoulder muscle that we have here, the deltoid, abduct the arm and abduct it in different positions, so it can be anteriorly or posteriorly. It helps to extend and a little bit of flex the shoulder at the same time. It's a challenging muscle also to work it out with weights. Even with minimal weight, it feels a lot of pain when you are working it out. And then we have the pectoralis major that helps to adduct. So basically it's antagonistic of the deltoid, abduct and medially rotates the arm. So that's the pectoralis major. And then for coracobrachialis, flexes and abducts the arm. Now, for flexors of the elbow, we have the biceps brachii has two heads, the long and the short head. The long head, it flexes the elbow and supinates the arm. Flexing and supinating. And then actually it's this way, guys, sorry. It's doing this way. Flexing and supinating. And now the short head assists in the flexion of the elbow, but also in adduction. So basically it's doing this of the forearm. Now brachialis itself is the primary elbow flexor. The biceps brachii, it also flexes, but the main one is the brachialis, which runs here lateral to the biceps. And then the brachioradialis flexes the forearm at the elbow. So it is a synergist of flexion of the elbow. Now for the posterior muscles of the arm, so we have, of the shoulder area and the arm. So we have the rotator cuff muscles, which help us to stabilize the head of the humerus over the glenoid cavity. We have 4 of them with the acronym SITS: supraspinatus, infraspinatus, teres minor, and teres major. So one way to remember is this acronym. So supraspinatus, infraspinatus, then here will be the teres, and the, actually, what? I'm missing an S. Well, it's just like that. So some people that has damage to one of these muscles, it can have dislocation of the humerus or the shoulder. Okay? So it helps to stabilize the head of the humerus over the glenoid cavity by laterally rotating the arm like this, these two, and this one extends and medially rotates the arm, and this one abducts the arm. Now, the extensor of the elbow that we have in the posterior area of our arm will be the triceps brachii. The triceps brachii has three heads, lateral, long head, and medial head, but these two, the ones that are more powerful to extend the elbow will be the lateral head and the long head, and also helps to extend the shoulder, like this. Now, latissimus dorsi, which is this broad muscle that we have here, extends, adducts, and medially rotates the arm. So this latissimus dorsi, together with this trapezius, is well developed in swimmers. They use it a lot because they have to do a lot of circumduction in order to swim fast. And then anconeus is a tiny muscle that we have here in the lateral epicondyle area of the humerus that helps to the triceps to extend the elbow. So then here we have the anterior view of this muscle. So this is the deltoid. Remember, this is a multipennate muscle. So since the fibers runs in different direction, help us to abduct our arm in different directions. And then here we have the biceps brachii. The long head is lateral. The short head, it is medial. It inserts into the ulna and into the radius in the tuberosities. And then here we have the brachialis, the ending of the brachialis, and here is the brachioradialis. So the brachialis is a little bit deep to the biceps brachii. And then here we have the supraspinatus muscle. It's above the spine, that's why it's called supraspinatus. This, since it's below the spine, this will be the infraspinatus. And here we have teres minor and teres major. All of these inserts into the greater tubercle of the humerus. So it helps again to stabilize this humeral head into the glenoid cavity. And then here we have the lateral head of the triceps. This is the long head of the triceps. Here's the anconeus. And here is the latissimus dorsi. It is very broad and is located in the inferior portion of our back. Before we talk about these muscles of the forearm, let me give you a generality. Everything here flexes, everything in the anterior compartment flexes, whether the fingers, the carpi, or the elbow. Everything posteriorly extends, fingers, carpi, elbow. So, in the anterior compartment of the forearm, we have flexors of the wrist and the fingers. Flexors of the wrist, of course, will have the name carpi, because carpi means wrist. And then we have two, radialis and ulnaris. Radialis is in the radial side, ulnaris is in the ulnar side. Not only this flexes the carpi, but also, based on location, they can abduct and adduct the wrist, doing this. So, tell me which one can adduct the wrist, the flexor carpi ulnaris or the flexor carpi radialis? Which one can help us to do this? Where do we have the radius? Laterally or medially? Because the name is based on the bone as well. So where do we have the radius? Radius is lateral, I heard it. So then, if you're abducting ADD, which muscle are you using? Flexor carpi radialis or flexor carpi ulnaris? Huh? Say it again. Ulnaris, because this is the area where we have it, in the ulnar side. And then what do you expect will be the action of the radialis? Adduction or abduction of the carpi? Abduction, so you will be doing this. So then you can do this with the ulnaris, and then you can do this with the radialis. And then we have flexors of the digits, which will be second through fifth. So 2, 3, 4, and 5. Fingers 2, 3, 4, and 5. So we have flexor digitorum superficialis, and then flexor digitorum profundus. So this one, the superficialis, flexes middle phalanges, while the profundus will be the distal phalanges. So we have proximal, middle, and distal only in these ones. But in this one, we have only proximal and distal. So if the superficialis flexes the middle phalanges, we'll be doing something like this. And then for the profundus, which flexes the distal phalanges, we'll be doing this. It's hard. So the one that flexes the middle phalange, it's like this, and the other one, if we had it perfectly extended, we'll be doing this. And it is helpful, like when you grab an object that is very, very wide, or for instance, when you're carrying an object, you're helping someone that has an edge like a desk, you will be using your flexor digitorum profundus. And then you will be like this. Okay? So now, for our thumb, we have one specific that is called flexor pollicis longus. It flexes the thumb. Okay? So it does this. So all of these tendons from these muscles runs under a membrane that runs like this in our carpi that is called the flexor retinaculum. So then you have a nice sliding of all of these flexors. So then when you do this, you can feel your tendons in here. Those are the flexors. And then when you do the opposite, you feel the extensors. You can see them. So this is the anterior view of the muscles of the forearm with the flexors and other ones. So in this region, we not only have the flexors, but also we have the pronators. And in the posterior region, we have the extensors and the supinators. So then, this is medial and this is lateral. So here we have the brachioradialis, and then this is the pronator teres. This is the flexor carpi radialis. This is the palmaris longus that tenses the palm. So like when you do this, like stop, you are using this palmaris longus. And then this one will be the flexor carpi ulnaris. So the palmaris longus then is between the flexor carpi ulnaris and the flexor carpi radialis. And then here you have the pronator teres between the brachioradialis and the flexor carpi radialis. And then of course here in this edge, we have the extensor carpi radialis longus that it can be seen better on the posterior side. Now, these are superficial muscles. So here we have the tendons of the flexor digitorum superficialis. Now, deeply, if you remove part of these muscles, then you can see this flexor digitorum superficialis. So you have to remove all of these so you can see it. And then it extends the tendons up to the middle phalange. So that's why we can do this, okay? And then here we have the flexor retinaculum that allows all these tendons to slide really neatly. And then here is the tendon of the flexor pollicis longus that they removed. And here is the tendon of the flexor carpi ulnaris that also has been cut. Now, if you remove this flexor flexor digitorum superficialis, you will be able to see the flexor digitorum profundus, where you have the insertion of the tendons up to the distal phalange of the fingers, 2, 3, 4, and 5. And then this one, it has its own flexor, which is the flexor pollicis longus. So this and this are, if you wanted to see it that way, are more important than this, but this one is more important than this, the superficials. Remember, everything that is more fragile or has better, or well, not better function, but more important function, it's always deep in the body. And then here we have the supinator and the pronator quadratus in this region. Once we talk about the extensors, I will tell you like the physiological point of why we have the muscles where we have them. So then the extensors are located in the posterior compartment, and they extend and move the wrist and the fingers. It's just like the flexors, but they are extending. Okay, they extend the fingers, the carpi, and the elbow. So we have extensor carpi radialis, extensor carpi ulnaris. So in the case of the extensor carpi radialis, we have longus and brevis. So one is longer, the other one is short, and they extend and abduct the wrist. So extend and abduct the wrist. And then, so this one It can be used, for instance, to beat, when you're beating eggs, or whipping cream. Also for tennis players, they use it a lot to grab the racket. And then for extensor carpi ulnaris, extend and adducts the wrist. Now, for the extensor digitorum, we have extension of the fingers 2 through 5, and then we have extensors specifically for the thumb. We have longus and brevis, and then we have an abductor for the thumb, which is called abductor pollicis longus. So just as for the flexors, the tendons of these muscles passes through the extensor retinaculum, which in this case will be located in this area posteriorly. And these muscles, the extensors, with the exception of these pollicis longus and brevis, which is innervated by the ulnar nerve, are innervated by the radial nerve. Now the flexors are innervated by the median nerve, and then the biceps brachii by the musculocutaneous, triceps by the radial nerve. So this is the location of these muscles. So this is the superficial view of the posterior part of our forearm. So here we have the extensor carpi radialis longus. Here we have the extensor pollicis brevis, extensor pollicis longus, and then here we have the abductor pollicis longus. This is the extensor digitorum, extensor carpi ulnaris, and extensor digiti minimi, which extends this pinky. And then here we have the flexor carpi ulnaris seen from the posterior view. Now, if you remove these muscles, you will be able to see the deep muscles, which you can even still see the anconeus, which extends the elbow. We have here the supinator and abductor pollicis longus. Here we have the extensor pollicis brevis, extensor pollicis longus, and then extensor indicis. So we have one specifically for the index. So physiologically speaking, flexion of our fingers and our carpi is more important than extension. One of the reasons then why we don't walk in the anatomical position unless you're a model of anatomy, why we keep this anterior compartment with the flexors posteriorly, is because it's more likely that we receive an injury from the anterior area. And if we receive an injury from the anterior area, we may damage the extensors, but not the flexors. What will be the use if you damage your flexors and you can extend the fingers, you have them extended, and then you can extend the carpi? What will be the use for eating? So it's more important this because you can grab objects, right? You can grab food and you can put it in your mouth. It doesn't matter if you cannot extend. As long as you can do that, it's useful for life. And then that's why we have flexor digitorum profundus and superficialis. Just in case that for any bad luck, you damage your superficialis, you still have your profundus. And crazy enough, we have a specific muscle to extend the index. And we have it, of course, close to the body, protected by our body itself. It's not so exposed as the lateral region, right? You keep it medially. Why do you think is that? Why would we need that muscle and protect it? Use that muscle. Use it right now. Extensor indices. Sorry, index. Yeah, extensor indices. Use it. It's for pointing. There. I need that. You might not be able to talk, but you can point. And then, of course, we love that we have a lot of mobility with our thumb. That's what it helps us also to grab objects and to text, to communicate. Okay? Okay, now the muscles of the hand are subdivided into two major regions, tenar and hypotenar. But we also have additional muscles like the lumbricals and the interossei. So for the tenar, which will be located here in the thumb area, we have this abductor pollicis brevis. We have the flexor pollicis brevis, opponens pollicis, and abductor pollicis. Pollicis is referring to the thumb. Here are the actions. This one abducts, this one flexes, this one opposes, and this one adducts. Okay? And then hypotenar will be these muscles in here. Like we have the abductor digiti minimi. We have flexor digiti minimi. You have to work them a little bit to prevent these other ones from moving, but once you can tame them, I guess you can do flexion of the fifth finger and opposing. Not the other fingers like this one, the opponent's pollicis, it can oppose all the fingers, the pinky, ring, middle, indices. But this one can only oppose this, of course, because of the position. And then the lumbricals, they flex the metacarpophalangeal joint, so it helps us to do this. And they extend the interphalangeal joints of fingers through 2 through 5, depending on which are the interossals, whether they're anterior, which help us to do this, flexing, or the posterior. So if it's the ventral, help us to do this. If it's the dorsal, help us to extend. So those are the interossei. And they are also innervated by the radial nerve. Sorry, those are the lumbricals. And now for the palmar interossei, adducts fingers, brings them together. And then dorsal interossei abducts the fingers, spread them apart. So pad, dab. That's kind of the mnemonic, pad, dab. So this will be palmar interossei, so that means that they are in between the muscles of the palm, or sorry, the bones of the palm. So these ones adduct fingers. And then dab will be dorsal interossei, abducts, remember, AD, and abducts, fingers. So, which one we typically use? Will be the palmar, because we don't do this all the time, right? We keep them adducted. So we use palmar interossei. And then if you find them out, that will be dorsal interossei. So here is the location of all of these muscles. So here we have the tenor, hypotenor. Hypotenor, we have adductor digiti minimi, flexor digiti minimi. This is the superficial layer. And this, in the tenor region, we have the abductor pollicis brevis, flexor pollicis brevis, and adductor pollicis. And then here we have first, second, third, and fourth lumbricals. That's the superficial layer. If you remove them, you can see the deep layer. So this is the opponent's digiti minimi, and these are the dorsal interossei that help us together with the palmar interossei to abduct or adduct our fingers. And here we have the adductor pollicis that it is protected by these other muscles, which are the abductor, the opponents, and the flexor. Here are the lumbricals, first, second, third, and fourth lumbricals. Palmar interossei and dorsal interossei. Dorsal interossei are broader than the palmar interossei. Why do you think is that? Had that? What does the palmar do? Adducts, right? So this one doesn't require as much muscular mass because this is basically a passive movement, natural movement that we have. But if you want to spread your fingers, that takes more muscular mass, more force. So that's why these ones, the dorsal interossei, are are more muscular, more massive. Okay, now let's look at the muscles of the thigh and the leg. So we have flexors and rotators of the thigh, which are iliacus, psoas major, sartorius, and tensor fasciae latae. So flexors, they are located majorly in the dorsal part of our thigh and also lateral part of our thigh. And then anteriorly in our thigh, we have this bulk muscle that we call the quadriceps femoris or quads. It has 4 heads. The medial and superficial head will be the vastus intermedius, will be bounded by the vastus lateralis lateral and the vastus medialis medially. Sorry, the rectus femoris is the most medial and superficial. And it has on the side the vastus lateralis and medially has the vastus medialis. And then if you remove the rectus femoris, underneath you will have the vastus intermedius. And as a whole, it helps us to extend our knee. So it's a primary knee extensor. Now for the adductors, we have several of them. We have them here located in this middle area and anteriorly in our thigh. We have these three, which are adductor magnus, that not only adducts the thigh, but also medially rotates the thigh, like doing this. And then we have adductor longus and brevis, and we have pectineus, which is very tiny, and we have the gracilis that runs medially and reaches the medial condyles of the tibia. So it helps also to flex the leg and medially rotate the thigh. So here we have these muscles. So this is the quadriceps femoris with the rectus femoris, vastus lateralis, vastus medialis. This is the tensor fascia latae. This is the sartorius, gracilis, pectineus, adductor magnus, longus, and then adductor magnus in here, and this is the iliopsoas. If you remove these, you will be able to see adductor brevis, longus, and magnus. And here is the pectineus cut. Deeper to this rectus femoris, we have the vastus intermedius. So that is all for this second part of the chapter. Do you have any questions?